retrospective study of outcomes for nasopharyngeal cancer survivors with radiation-induced sarcoma in ENT perspective. So I'm Samuel Cheng, a resident of Prince of Wales Hospital. So let's talk about some radiation-induced sarcoma definition. To diagnose this disease, one should meet all the following three criteria. First, tumor should occur within a previously irradiated field. Secondly, there should be a histological proof of sarcoma, and it should be different from the primary cancer histology. And thirdly, the tumor should arise at least 3 years after irradiation. In fact, different papers have quoted different figures about the latency, range from 6 months to 5 years. In general, an arbitrary time frame of 3 years has been used as a cutoff based on a loose consensus that it is a sufficient time gap for radiation carcinogenesis to occur. So radiation-induced sarcoma is a rare complication as mentioned by different specialty. And it's about the incidence about like 0.2%. And Hong Kong is endemic for nasopharyngeal cancer with radiation therapy as a primary treatment. So we have many long-term survivors following up in our clinic. This gives us a unique position to study radiation-induced sarcoma in head and neck region. So in our retrospective study, we have two questions. First, how are the clinical pathological features and outcomes of radiation-induced sarcoma on NPV survivors different from de novo survivor? And secondly, what are the prognostic factors for these radiation-induced sarcoma in NPC survivors? So this is a retrospective review recruiting head and neck sarcoma patients managed in our department from 2009 and 2019. We retrieved data from a CDS database and our Dendroid database. The head and neck sarcoma patient we recruited is either radiation-induced sarcoma with history of NBC and RT done, or de novo sarcoma. Pediatric patients or patients with inadequate clinical information are excluded. So we have two groups, the radiation-induced group with history of NBC and de novo group. We have 22 patients in a radiation-induced group and 18 patients in a de novo group. So let's look at the demographics. As mentioned by Dr. Long before, male predominates in both groups, constituting about 70% of each group. For age of diagnosis, although their means are similar, about 50-year-old, however, the age distributions are different. Most of the patients in radiation-induced group are of 40 to 60 years old. And it is actually not difficult to understand because NPC most commonly occurs in young adult, and it takes several years for radiation-induced sarcoma to occur. On the other hand, de novo group has a wider range of ages, including young adult and elderly. Smoking and drinking status are similar between two groups. So let's move forward to histological subtypes. There is a significant difference here. According to our data, the most common histological subtypes of radiation-induced group is actually sarcoma NOS. It means that actually it did not show any specific differentiation based on the histological or morphology phenomenon. So, second commonness is actually osteosarcoma. On the other hand, for the de novo sarcoma group, it has a more diverse in histological subtypes. You can see that the most common histological subtype is angiosarcoma, which is mainly occurring at the scalp and skin or head and neck region. And other than that, almost each patient has a different type of sarcoma. So tumor location is also quite different between two groups. Radiation-induced group mainly occur at neck and nasopharynx region, both together consisting of about 60% of the group. De novo group, again, has a more diverse in locations, in which scalp, maxilla, oral cavity, oropharynx are the most common. And thanks to the AJCC, the newest 8th edition, we now have a TMN staging specific for head and neck sarcoma. And all of our patients are restaged into the new TMN classification according to the size and surrounding structures involvement, as documented in their pathological and imaging reports. So here, we can see that the radiation-induced group tends to present late. Most patients already at its advanced T staging upon presentation. 72% present as T4. On the other hand, the de novo group, there's only about 40% as present earlier as just T1 to 2 stage. This could be related to the complication of RT, including severe neck fibrosis, which may mask the early tumor and makes small and neck sarcoma less easily to be identified early. This could also be related to a preferential location of the tumor. For example, angiosarcoma in de novo group often present in the skin or scalp, which is more superficial and easier to be identified early. And for the end staging, you can see that both groups are similar. Only 20% have N1 disease. According to our data for the treatment modality, most of the patients in each group receive surgery. Patients not receiving surgery are mostly due to inoperable advanced disease. For all the patients, just 2 operable patients refuse surgery. So in the radiation group, among operated patients, we can see that only 1/3 of the patient receive adjuvant therapy, and 2/3 just receive surgery alone. This is due to after previous radiation therapy, often there could be only limited window for radiation, as it may cause severe radiation therapy-related complications. And on the other hand, all the operated patients in the de novo group receive neoadjuvant or adjuvant therapy. So this is the Kaplan-Meier survival curve showing the overall survival of radiation and de novo group of sarcoma. For the de novo group, it has a significantly better overall survival than the radiation-induced group, with 2-year and 5-year overall survival, 62% and 52% respectively, compared to just about 40% and 30% in the radiation group. We further stratified each group into operated and non-operated subgroups. We can see that both the non-operated subgroups, the radiation-induced group by the purple line and the de novo group by the green curve, have similarly poor survival, and most patients died within 2 years. And their operated counterparts have significantly better overall survival than them. So for both radiation and de novo sarcoma, surgery is a mainstay for treatment modality, which gives us a significant survival benefit. The recurrence pattern is also different. Almost 90% in radiation group recur locally, and only 10% has distant recurrence. In contrast to these, de novo sarcoma has more distal recurrence. So let's come to our second research question. What are the prognostic factors for radiation-induced sarcoma in NPC survivors? We actually try to list out several disease parameters and perform univariate analysis for each of them, and trying to identify if there's any relationship between the survivals. Among them, only surgery and resection margin status have significant relationship between these survivals, and sample size is too small for multivariate analysis. So for patients received surgery, there is significant survival benefit than those who didn't, as I mentioned before. The 2-year survival is about 60% in 5 years, and 5 years is still about 40%, whereas all the non-operated patients die within 2 years' time. And here are the Kaplan-Meier curves showing the overall survival of clear margin versus positive margin. We use 1 mm, 1 millimeters, and as cutoff. Margins less than 1 millimeters are regarded as positive margins. So you can see that the clear margin patients have significant better survival in this diagram. And it is also worth noting that achieving clear margins may also have disease-free survival benefit, which is defined as latency after treatment to date of recurrence. So reviewing the whole study, one of the main limitations is small sample size. So in the future, we will cooperate with other centers to perform a more statistically significant study. It is also difficult to perform some subgroup analysis and multivariate analysis, as I just mentioned before. So I think a multi-hospital collaboration is needed in the future. So to conclude my study, so for radiation-induced sarcoma in NPC survivors, there are quite many points different from the de novo sarcoma, including the age distribution, the histological subtypes, anatomical location, T staging, and also treatment modality are quite different. And radiation-induced sarcoma in general has a worse overall survival, and it tends to recur locally. Surgery is mainstay of treatment, which offers a survival benefit for both groups. And for prognostic factors for radiation-induced sarcoma, I think receiving surgery and also achieving a clear margins is significant to have a better overall survival. So thank you very much for your time, and I especially thank my seniors and colleagues to support me in this study, including Dr. Jason Chen, also Eddie Wong. Thank you so much, and we leave the question to later after all the presentation. Thank you.